Okay, here. So for question number 2, it asks us to talk about the tubuloglomerular feedback. And so we're going to start with a couple different things. We'll start with osmoreceptors and baroreceptors. So first, osmoreceptors, because blood ion concentration is one of the biggest signs that the human body has. So these osmoreceptors are located in the hypothalamus, and they regulate the blood ion concentration. So if there's a higher ion concentration in the blood, or there's a sense of dehydration, these osmoreceptors will release water to bring back to equilibrium. And what happens is, as these osmoreceptors release water, they will shrink, which causes action potentials in the posterior pituitary gland, which leads to the increase in release of ADH, or antidiuretic hormone. We've talked about baroreceptors previously, and we know that they are based on stretch. And so when there is a decrease or a lack of stretch, that will lead to an increase in secretion of ADH. And the opposite is true. If there's an increase in stretch and blood pressure, that will lead to a reduction in the secretion of ADH. So these two receptors are the main players in this type of feedback that we're talking about here. Okay, so now what we're going to talk about is what's called the renin-angiotensin-aldosterone system. So this here is kind of like a flow chart that I'm going to fill out and talk about. That kind of helps us understand the different effects of the renin, angiotensin, and aldosterone within our body and the cycle that it goes through. So we start here with angiotensinogen, which we know is made by the liver and put into the bloodstream. And so we have this angiotensinogen in our bloodstream, and what we need to add to it is a chemical called renin, which is made by the kidney. And the release of renin to the blood flow is stimulated via a low GFR. So when we have a low GFR, the kidney releases renin into the blood flow that combines with angiotensinogen and turns it into angiotensin 1 here. And so we know that angiotensin 1, in order to go to angiotensin 2, we need what's called an ACE. And the ACE stands for angiotensin converting enzyme. And so this will cause our angiotensin 1 to go here to angiotensin 2. And so angiotensin 2 has 4 main pathways that it undergoes in order to regulate different things throughout the body. So we'll go ahead and talk about each one of those 4 things. So with angiotensin 2, we know that it will undergo these 4 pathways. So first, it will go to the brain, and it will do things like increase the secretion of ADH, and that will cause an increase in things like thirst. We will become more thirsty because of that. The angiotensin 2 in the kidneys will cause constriction of the efferent arteriole. Angiotensin 2 will activate the adrenal gland, which will release aldosterone. And what aldosterone does is it increases function of sodium-potassium pumps, which causes an increase in blood pressure to regulate that increase of potassium. And we also have system-wide vasoconstriction, which also leads to an increase in blood pressure. So each one of these things with angiotensin 2 are different regulatory pathways for our body. And so because a lot of these things result in an increased blood pressure, when our blood pressure becomes too high, people will take medications called ACE inhibitors. And so ACE inhibitors will take out this ACE coming in to convert angiotensin 1 to angiotensin 2. And so this entire pathway will be taken out. And so angiotensin 1 will never be able to go to angiotensin 2. And all of these things won't be able to happen as frequently, which will cause the blood pressure of the patient to go down. So if they have normally high or too high blood pressure, people take ACE inhibitors. It's a really common drug to lower overall blood pressure. Okay, so now when talking about the loop of Henle, go ahead and draw kind of a rough drawing that will hopefully show what we're talking about here. So this, we have the nephron, and we're going to highlight this area here of the loop of Henle. So what happens is we will start with a concentration of about 300 milliosmoles that will come in to the loop of Henle, the descending loop. And so what we know is that water is able to leave the descending loop into the medullary space. And so say this 300 gets all around up into here. Well, we know that the ascending loop of Henle wants to have a difference between the medullary space and this space of 200. So what we need to do is cause this to go to 200. So what happens is we know that sodium is able to leave, sodium and chloride is able to leave here into the medullary space. So that will lower this concentration down to about 200. And so if this sodium leaves, then that will increase the concentration here. And if we have an increased concentration here on the outside, then we know that this water will leave the descending limb and will cause a equilibrium to be reached here at this end. And so as we have this continual movement down the descending and up the ascending, we will have this continual process of the higher concentration coming down into the bottom of the loop, and once it reaches the ascending loop, then the solutes will leave. So this space right here will be really, really salty because all of these solutes will leave, and we will establish kind of a gradient where as we go down the descending, we will have an increasing gradient, and once we go up, we will have a decreasing gradient. So this is kind of a loop that happens of filtration in juxtamedullary nephrons, where we will come in at 300 all the time, and we will have the increasing concentration come over to the ascending, and we see this high concentration of the ascending will cause the sodium to leave, which will make this area really salty, highly concentrated, which will cause the water to leave as well, which leads to the increase in concentration. So this is kind of the loop that we discover that is happening in the loop of Henle that kind of establishes this gradient. So using this concentration gradient that we have established here, we have the collecting duct. And so we know that ADH, or antidiuretic hormone, is only present here on the collecting duct. And what happens is here we have aquaporins along the collecting duct. And what ADH will do is it will come and bind to these aquaporins, and that will allow the release of water, the reabsorption of water back into this space here. So we know that if we have an increased amount of ADH, we will have more open aquaporins that allow water to be reabsorbed. So this regulation of the renin, angiotensin, aldosterone system and the fluctuating amount of ADH that the body produces will directly affect this reabsorption of water from the collecting duct. So if we have more ADH, we will have a more concentrated urine leaving the collecting duct because this water will have been reabsorbed. If we have less ADH, then that will keep this water inside of the collecting duct and we will have a more dilute urine. So based on this concentration gradient that is established in the loop of Henle, and once we get to the collecting duct, the amount of ADH that the body releases will determine the amount of water that can be reabsorbed through the collecting duct, and which will ultimately cause the difference in concentration of our urine based on what our body needs.